I'm Nick Savva. I'm an orthopaedic foot and ankle surgeon. I work here at Fortius in London, and I also work in Dorset in Dorchester. I specialise in all aspects of foot and ankle surgery, including trauma, sports injuries, arthritis and toe deformities. Good evening everybody, thank you very much for coming. So I decided to talk about Lisfranc injuries. I've seen a few of these recently at home. So windsurfing, I don't know if any of you know about windsurfing. Windsurfing is a sport that's been around since sort of the 60s and 70s. The thing about these characters that do this sort of thing is they have their feet in straps which are quite loose, so your foot can come out of them relatively easily. Of the serious injuries, most of them are lower limb injuries. Obviously there are some pretty nasty things that happen. Wakeboarding is altogether different. You're pulled along by a big powerful boat and you're actually strapped in very hard. I don't know if any of you have ever had a go at this, but you actually have to use something like fairy liquid to get your feet into the bindings because they're so tight. And so we see 1 or 2 patients every year with a fracture of their tibia, rather like skiing, just above the bindings. And interestingly, a fair number of knee injuries, ACL and MCL injuries, because one foot often comes out, leaving the other with this huge lever arm on that then twists their knee. But again, you do see the odd foot injury because the sportsmen jump and land awkwardly on their feet. But then again, there's all these other odd injuries, including fingertip avulsions from holding onto the rope or wrapping your fingers around the rope. Kitesurfing is very, very popular, more popular than windsurfing, and is very dangerous when you're on the beach. The kite pulls you along, which is extremely powerful, and when you're on the beach, if the wind catches it or somebody launches your kite, you end up being launched over the car park, over the road, all sorts of terrible places. The foot is relatively well protected in kitesurfing because it's just in a soft strap on a board that falls off relatively easily. But rather like wakeboarding, sometimes one foot comes out, causing regular knee injuries. The majority of serious injuries, however, are feet and head injuries in the car park. Skimboarding, I love this picture. Skimboarding, the average age of the skimboarder is under 16. So this bloke is clearly trying to look under 16. But interestingly, what you do is it's based on the premise that you put a board on the water that's aquaplanes and you jump on it and it skids along. But if you watch someone doing it on the beach when they're learning, occasionally it sticks hard and they just fall straight over. So most injuries are broken wrists and broken ankles in kids. Surfing, it's quite hard to hurt yourself surfing actually on the board because it gets washed away. The commonest injuries are head injuries from being hit by the board when the leash comes and wangs it back, or being hit on the bottom. Lisfranc injuries were originally described in people that rode horses. This is where it gets really tenuous, like a horse in the water. Because of the foot in the stirrup. So the foot's in the stirrup across, you're supposed to just have your toes in, but occasionally if you fall, your whole foot goes in or your toes get caught, and then of course you fall off and your forefoot is twisted on your midfoot, or your midfoot is twisted on your hindfoot, causing these injuries. This is where the name comes from. This French chap was a Napoleonic surgeon. I actually requested the French language paper, but then couldn't translate it. But he actually was supposedly Napoleon's surgeon. I think he was actually just a Napoleonic era surgeon who described the joint and injuries to it. And of course the treatment then, because a lot of these injuries were compound, was amputation. So onto the Lisfranc bit. So where the Lisfranc joint is here. It's the joint between the tarsometatarsal, the metatarsals and the cuneiforms and the cuboid here. And it's sort of the most important part that forms the medial longitudinal arch and the transverse arch of the foot. And that's maintained by the shape of the bones. So you can see they're triangular, rather like keystones in a Roman arch. And then in the transverse plane, the second is set back rather like a keystone in an arch. And so it's a rigid, bony structure. There's 3 columns, or there are said to be 3 columns. The medial column is really quite mobile, with sort of 10, 15 degrees of up and down movement in most people. The middle column, which is the second and third, is really quite stiff because of the keystone effect. And the fourth and fifth are really very mobile, with 30 degrees of movement. Now, it's quite understandable why the medial side is so mobile when you consider what we've evolved from. Our foot originally was used for grasping things. It's not opposable like a thumb is, but you were certainly able to do a fist sort of grip with our thumb when we were still essentially climbing trees. And we've evolved over to a foot which is a much more stiff platform, which allows side-to-side movement for walking on uneven ground, but as soon as we go to push off, turns into a stiff peg that we can push off from. But there is still relative mobility in the first ray, which explains the anatomy of the ligaments. Oops. So the anatomy of the ligaments is interesting. The dorsal ligaments, rather like on the wrist, are weak and not terribly important. The intertarsal ligaments, so the ligaments sort of deep within the foot, are very significant. So there are intertarsal ligaments for all of the metatarsals, except one between the first and second metatarsal. And that's because this is still relatively mobile from the day when we were using our foot as a fist. And in fact, if you think about the first ray, there's only 1, 2, 3 bones before here, isn't there? And in the others, there's 1, 2, 3, 4, and then this. And so this Lisfranc ligament, the intermetatarsal ligament, is actually the equivalent of the intertarsal ligament if you look at it phylogenetically. On the plantar surface, there's another very important ligament, the bifurcate ligament, which goes from the medial cuneiform to the second and the third, and you occasionally see avulsion fractures of these. And so we probably should think about a complex of ligaments and a joint that transverses the whole midfoot. Just while I've got this slide up, it's very important to look at the alignment. You never see this view like this on a plain x-ray because of the arches. If you take a view down through a foot, you never see that lined up as it is. But you do if you take various oblique views. The most important thing if you ever get presented with an x-ray from somebody that comes back from a water sports holiday or a skiing holiday or whatever, is the alignment of these bones. So the first always aligns with the medial cuneiform, the second with the middle, the third with the lateral, and then the fourth and fifth with the cuboid. And that is invariable. The gaps vary, and I'll talk about that a bit later, but those alignments are very regular. So the mechanism of injury varies considerably. Something that we see more and more these days because we're becoming much more aware are subtle injuries in athletes. So the mechanism in those people is usually a twisting movement on a loaded forefoot. The commonest way of doing it is a car crash, actually, these days. But having somebody land on the back of your foot, this is a classic sort of American football thing, you're kneeling down doing something on an American football pitch and somebody lands on the top of your foot. That's someone falling out of the stirrup of their horse and, of course, a windsurfing foot strap. 80% of patients with these that present to us are multiply injured from either a fall or a jump or a car crash. But the sports injury thing is becoming much more common because we're getting better at spotting them. So how do they present? Well, the multiply injured patient is pretty obvious because their foot is very swollen and we'll have picked it up early on in their sort of secondary survey of the ATLS thing. But in the sports injury patient, you need to be very aware of this bruising on the bottom of the foot. Somebody with a normal soft tissue injury to their foot or their ankle won't have bruising on the sole of their foot because you need to have ruptured either the plantar or the interosseous ligaments to get blood flowing down into the sole of the foot. So look out for that. They have a tender, painful midfoot. They often say that their foot feels unstable, and what they're describing is the midfoot collapsing as they stand on it. Athletes are many athletes are very stoical, and so they usually shrug it off and try and get on with it. Don't forget there's another foot to compare it to. And then again, don't forget you can injure both at the same time, particularly people who are in foot straps with both feet. So the multiple injuries are pretty obvious, pretty easy to pick up. On the first examination, that looks normal, doesn't it? Until you realise that should be there. So this guy jumped off a bridge, did this to both feet, and you can see the second is smashed to smithereens. And so the alignment's completely wrong. That bit of bone there should be there. But interestingly, the fifth, look, is in the right place, fortunately. This is much more subtle. In a patient with a bruised foot like we just saw, we'd always take an x-ray, and you sometimes see this little flex sign. Can you see there's a little avulsion of bone there? And actually, when you look a little more carefully over this side, it doesn't look quite normal. And there's a reminder of the alignment of what it should look like, in that the edge of the second metatarsal should align with the medial side of the middle cuneiform, and it's not. But you've just got to be very vigilant to see them. Sometimes taking the patient to theatre and stressing the bones is the only way you can find out if there's instability. So you can do CT scans, MRI scans and so on, but this is a very useful way, if you're planning on operating on them, of finding out if something's subluxing. So you can see here the first metatarsal has popped up compared to the middle cuneiform when I've got hold of his foot and wrenched it in front of an x-ray machine with him asleep, because you'd never, of course, do it with them awake. And you can also see an avulsion there with the eye of faith of the plantar surface of the second metatarsal. The reason it's difficult is that some of these gaps are very variable. The gap between the first and the second metatarsal, if you read various papers, is measured anything from 1 to 3 millimetres. Weight-bearing views are extremely important at loading the foot, so you need the patient to be able to stand on it. But here, you get the impression that this is abnormal. It looks sort of 2 or 3 millimetres to me, so I'd have a high index of suspicion about that foot. So I always get a comparative X-ray of right and left, which causes the radiographers to jump up and down because they really don't like taking X-rays of the normal side, but we insist in this situation. CT scans can be very helpful in surgical planning. Here you can see, again, you can reconstruct the slices in any plane you like, and you can see that the first metatarsal isn't lined up with the medial cuneiform, and there's actually a fracture of the base of the second. It's left its keystone bit behind and translated across laterally. For the very subtle injuries, MRI scans can be extremely useful because you can actually see the ligaments if you have a really good radiologist helping you, and that's a normal Lisfranc ligament, so the intertarsal ligament. So the major injuries are classified by Meyerson, who's a very famous American surgeon who's published lots on all sorts of different things. And these are about the patients that jump or in road traffic accidents. So in a really bad situation, the whole lot goes, often leaves a bit of the second metatarsal behind, and it can go laterally or it can go medially, and these are disastrous injuries. Sometimes, like in that chap that I showed you, one part is left behind, which is called partial incongruity. So the medial side can fracture off, or the lateral side can fracture off and drift, and that obviously depends on how you land or the deforming force at the time of the injury. And again, devastating injuries. And then the third part is where one goes one way and one goes the other, which requires a degree of force even further, which is, again, a devastating problem. The minor injuries have only recently been classified by Nunley and co. They base this on plain radiographs, clinical signs, and bone scans, interestingly, but you can extend that to an MRI scan, really. Stage 1 injuries are essentially a sprain with no deformity. So there's an injury to the Lisfranc ligament complex, a bruise on the bottom of the foot. They don't like standing on it, but the ligaments are intact, so you can treat it like a sprained ankle, essentially. And I'll talk about that a bit later, the treatment a bit later. Stage 2, which is a bit like the X-ray we saw earlier on, there's 2 to 5 millimetres of diastasis, so there's partial or complete rupture of that Lisfranc ligament, but it's mostly reduced. And when they stand on it, the gap opens up, but the foot doesn't truly flatten. And stage 3 is greater than 5 millimetres of diastasis. And when you look at a lateral standing view, you can actually see the middle of the foot sag on the X-ray. So what are the principles of treatment? Well, the principles of treatment of any sprain or fracture are to preserve the anatomy and function while the body heals itself, aren't they? And to avoid this situation. So if you leave an unstable midfoot, you end up with degenerative arthritis across the midfoot. So you can see here a sag in the middle of the foot. If you draw a line along the first metatarsal and a line along the neck of the talus, it should be a straight line. It's called Meary's line, and it should be a straight line. And you can see a sag in the middle there. And when you look at the AP view, you can see 3 of the 4 radiological signs of arthritis, in that there's loss of joint space, cysts, and subchondral sclerosis. The only thing you can't see is osteophytes. And so I can't promise you this is an old Lisfranc injury because I found it last week in clinic, but it's the sort of thing you do see. So how do we treat them? The most important thing is to pick the subtle ones up early on, because we know that leaving them and missing them, they do badly. So basically, you've got to pick them up early and then treat them. So you need a history of something that's going to likely to have caused it. So a loaded twisting injury of the middle of the foot, tenderness across the middle of the foot, normal weight-bearing X-rays or stress radiographs, which we repeat at a couple of weeks if they're still sore, to diagnose a grade 1 type injury. And if you have a grade 1 type injury, I would just rest them in a boot for a couple of weeks, reassess, and then get them going, possibly with some sort of orthotic arch support, aiming to get back to sport at somewhere between 6 weeks and 3 months. Treatment of the unstable injuries is much more controversial, and there's an awful lot in the literature which doesn't make it absolutely clear what you should do. If you have a significant displacement between the first and the second metatarsal, the injury isn't reduced, and so you need to reduce it. That's the theory. But how much displacement do you need? And that's where the real arguments are. And these are the patients that we take to theatre and stress the foot and then decide on the table exactly what we're going to do. Sometimes you can reduce them perfectly and put percutaneous screws across to hold them in place. The problem with that is that you're putting screws through joints that are normal, which causes damage and therefore has the potential to cause arthritis. And the traditional screw that's put in is this screw to replicate the Lisfranc ligament, but we occasionally augment it with other screws if there are other lines of injury. And these screws often loosen. Can you see that sort of black halo around that screw? As the patient walks on it, they loosen and they sometimes break or need to be taken out. So you're condemning the patient to 2 operations potentially if you do it this way. Also, it's very difficult to guarantee that you've perfectly reduced it, and there's no point in doing an operation unless you are going to perfectly reduce it, because the risk of arthritis is so high if you leave them unreduced. And so there is, well, we all have a very low threshold for opening them, so you can see that the bones are in exactly the right place. And if you've opened them, then you might as well reduce them with a plate or something that bridges the joint and doesn't damage the articular surface. There are some folk that use these tightrope things. Now, you know the tightropes that they use in the shoulder for popped ACJs and in the syndesmosis. There is a vogue for using those. Can you see one button there and one button there? It isn't terribly well reduced. And also this is a bioabsorbable screw, which obviously doesn't need to be reduced, but they're not very biomechanically effective. So what did we do with this unstable chap? Well, his second metatarsal was too comminuted to do anything with at all. And so we reduced it and bridged the joint with a plate and bridged the third with a plate and then put K-wires across the fourth and fifth to hold them reduced. And this demonstrates all the basic principles. You stiffen the medial column and the middle column because they're quite stiff already, and you put flexible fixation across the lateral column because it's quite good to leave a little bit of movement there. There's quite good evidence that if you primarily fuse these joints where there isn't a huge amount of movement anyway, they're much more likely to get back to walking and potentially sport. If you are just reducing them, then again you're going to have to take the plates out, and so the patient's going to need another operation. And we aim to do that about 3 months, with the patient going back to the sport at somewhere between 4 and 6. So what do we do with these patients post-operatively? Well, they're in a plaster for 6 weeks because they're proper injuries, a boot for 6 weeks after that, and then getting back to training and proper stuff at 3 to 6 months. So it's a significant injury. Fortunately, grade 3 injuries like that are very rare in athletes as an athletic injury. Sometimes you get athletes that are involved in car crashes and so on, but that's usually a career-ending problem. So how do they do? Well, low energy injuries do extremely well, particularly in athletes. High energy displaced injuries obviously do poorly, and we're just glad to get them back walking on a stiff, rigid foot. We know that delay in treatment and litigation worsens the prognosis. Only the vast majority, well, not the vast majority, 50% apparently, but the ones I see, most patients have some signs of osteoarthritis at a year after these type of injuries, but only something like 1 in 10 actually need a fusion operation for the arthritis. Most athletic patients go back to sport at about 3 to 4 months with the grade 1, grade 2 injuries. Unfortunately, grade 3 injuries are rare in athletes. So the most important thing is we need to raise our index of suspicion for the mild ones, because when the grade 2, 3 injuries are missed, they do badly. Early diagnosis and treatment gets excellent results. And as I've said, athletes with low end injuries do well, and high energy injuries do badly. Thank you.